All right. So I get the honor really of presenting the case today, which is perfect because this individual, I just saw her in clinic actually yesterday. I've been following her for some time. And if you want to pull that up, Sonia, when you get a second, no rush. But she's one of many that I think we're going to have this conversation about, to the point that we're actually going to likely have some form of an echo for transformative therapy based patients. So we're going to get so many of these, right? Should this individual have gene therapy? This individual wants gene therapy. What do we think about that? I have had 3 new referrals just this week for gene therapy. So, and I always start with, do you know that it's a bone marrow transplant? Because a lot of our individuals who are referred are coming from often sites that may not be as familiar with understanding the process, the procedure, and all of those things. So in this case, I wanted to kind of put that out there. So this young lady is actually not, I mean, she's young, she's 38. She has hemoglobin SS disease, and she's mostly followed by an outside hematologist who I share a couple of patients with, because he's actually probably one of the best community hematologists that we have around here. And he just wants me to see his patients to make sure that he's doing a good job, basically, or to give him advice or give the patients advice. And it's a little bit closer to her to see him, so she'll go see him and then come back and see me. And so we share, for lack of a better way to put it. So she does have an outpatient hematologist. She does have a primary care doctor as well, which I didn't put on here. And she's just coming in this time because, she and her mom heard the news, interested in gene therapy, and want to know more. She takes some PRN Percocet. PRN ibuprofen, is not on a long-acting opioid, and generally does well in terms of managing her pain, and was only in the hospital actually one time in 2023, but has had some severe infections in the past. And in fact, in 2022, was hospitalized for almost a month with a port infection that became a spinal osteomyelitis, leading to a laminectomy. But in 2023, only one admission. The medications that she's on are listed. The only one that I oddly manage is deferiprone, because her provider doesn't feel comfortable with it. So everything else he manages, and we do all of her iron overload management. And when she first came to me, she hadn't been on chelation for some time and was very iron overloaded. So we've really moved the needle there. So what's interesting about hers, though, is she has a history of acute chest, but also a history of 2 strokes at 9 months and 10 years of age. And her MR that we updated shows right encephalomalacia, but no significant vascular stenosis, despite pretty impressive, obvious old right-sided stroke. And she has had a DVT in the past. She was treated and has been off treatment now for several years. She's had a couple of ports. She's had her laminectomy. She's had a gallbladder removal. And those are her main surgical issues. She doesn't have any evidence of pulmonary hypertension, no symptoms, so we haven't done any further workup. She does have some significant iron overload. After, as a child, when she was seen at Children's, she was treated with chronic transfusions, and that was for many years. And then I guess technically was essentially twitched over to hydroxyurea. She's had a history of intermittent major depression. Right now, she feels quite well and doesn't feel like she has any evidence of that. You want to scroll down from there. Oops, that stuff is not right. So we need to erase the verbiage on the bottom. There we go. She is on hydroxyurea. She's alternating 1,000 to 1,500. We're probably gonna have to go down on that, in fact, because she recently presented with what looked like aplasia. And so we talked about that we needed to come down on that dose, and she's going to talk to her provider about that. She has some red cell alloimmunization, but nothing severe. Her vitals are fine and nothing exciting, and she has a great response to hydroxyurea. So white count is 6, hemoglobin is 11, MCV is 142. Really nothing exciting else to think about. She has 30% fetal hemoglobin and isn't inflamed. So she does quite well. We can stop sharing, Sonia. Overall, and she comes and wants gene therapy. And I really do think we're going to see quite a few individuals like this. And so I wanted to get overall thoughts. Is this someone that you all would consider for gene therapy? Doesn't matter which type, recognizing that she does have pain. She just doesn't come to the hospital very often. She has a lot more pain at home, was only admitted for 1 crisis last year. And I should have mentioned, does sometimes get IV fluid and pain management at her local hematologist. Thoughts?
Hi, this is children's. I think the question will be, how do we select the patient that is best suited to get this gene therapy? Because I think one of the challenges with this treatment is the cost. And if we do decide to select a patient, what is the criteria that the patient will have to meet that can be generalized to the other patients? So I think first question that I have is how I know in the approval they mentioned how much it costs, about several millions of dollars. Like, does the patient have an insurance that can cover the gene therapy if we're to go forward with it?
So I am gonna not, she does have insurance, she actually has private insurance, but I don't think it should be a question of cost. I think if you take cost first, we're leaving equity out. And so let's just play pretend for a minute and assume that, well, that a lot of, I can actually tell you, a lot of insurances are going to cover this therapy.
Okay.
Medicaid has not made that choice, but a lot of Medicaids actually are looking into it. And some are further along, such as Missouri, than others. So I think it is going to be approved, but we don't know, are they going to limit the slots per year or anything like that? I think the question that I'm trying to ask is this someone you guys would think is a good candidate for gene therapy, more from a biologic and pathologic standpoint?
Well, then in my opinion, yes, I think this would be a patient, especially given the history of complications she's had, and also the fact that this is something that she wants to do. Then I think, in my opinion, this would be a candidate for gene therapy.
Other thoughts? I will call on you. All right, because I see you here, Dr. O'Brien, what are your thoughts?
Can you hear me? My
Yes.
setup here is a little weird. I mean, I think the probably the most compelling history here for me is the strokes. And I think you said she had acute chest history as well, right?
She has,
So,
and yes, the question is, I mean, yes, I would hypothesize, right, that patients are at decreased risk for stroke after gene therapy, but we don't have the data. Not really.
right. I mean, I think that's right. I mean, it's the same dilemma we get stuck in with transplant too. I mean, right, there are no long-term comparative outcomes of appropriate disease-modifying therapy. But if it's really I mean, I guess a lot of this comes down to patients' preference, and right, if their preference is to go forward with this and be able to get off hydroxyurea, I think the biggest thing that honestly gives me pause, particularly, I can't keep track of which one's which. I think it's the Vertex that induces fetal hemoglobin, right?
Yeah.
I do worry a little bit. Are we actually taking a step backwards, right? I think it's a little trickier with the bluebird since you're inducing A instead, but hydroxyurea is already inducing fetal hemoglobin, right? And then you're losing the nitric oxide effects, you're losing the anti-inflammatory effects. So I don't know. I struggled with this too. I mean, in the current moment, I can't do gene therapy here yet, so I don't have to answer this question. But I think particularly people with highly morbid prior vascular complications, I think that's the most compelling situation to consider it. But I don't know. And that's why I think this patient's a little more compelling. You know, I have some people in their 30s who haven't had this. You know, I have one who I just saw who really has had a PE, but otherwise he just sort of has chronic pain. And right, I think that situation, I don't think there's likely to be benefit, right? But I do worry a bit, right, if we try to shift the needle and think about, you know, 20, 30, 40-year long-term outcomes, right, I think that's what we all want to get to. Is there, in these people with highly morbid vascular complications, is there a more compelling argument to make? I think maybe, right? But at the end of the day, there's certainly nowhere near data to support that you're actually improving the outcome. So I don't know. I think I'm on the spectrum of sickle cell docs. I'm on the skeptical end of the spectrum with gene therapy. I'm just not sure how really transformative it is at this point. And again, particularly with the Vertex product, I think it's really hard to know that we're not actually losing some beneficial effects switching from hydroxyurea to fetal hemoglobin induction via gene therapy.
I think you ask a really good question. I talk about this a lot without a lot of answers. And I have that same question about fetal hemoglobin, and I usually spend my time arguing with Matt Heaney about this because Matt and I love to have this conversation where I'm just not 100% convinced in fetal hemoglobin, and I'm a big fan of hemoglobin A overall, but he begs to differ. So we have this conversation constantly without obviously data one way or the other to prove one thing or the other. But all we know in terms of stroke is the data that we have that we've presented from Bluebird, which is that we did in the early part before we enriched the population for bad vaso-occlusive crisis as requested by the FDA. We did have 6 individuals who had a stroke, and all we know is that none of them have had a recurrent stroke. So very small number, the patients are getting follow-up MRIs, so we do really know that. So the data is valid, it's just small. And, if she had more vascular disease, I would be a lot more worried in terms of if we saw, moya, because in this case, she doesn't, we have not transplanted anybody with gene therapy with moya.
Right, and I think particularly, I think her strokes were like 6 years and 10 years, right? So
Yeah.
already has made it 20 plus years without stroke recurrence.
Yep.
So I don't know. I mean, and I think, right, it brings up the other question, right? If both gene therapies are actually available for particular patients, how do you approach which one to do?
And I think that's a great question. I mean, because I get asked that all the time. My only answer at the moment is I've done a lot more and we have a lot longer durability of follow-up on people who've gotten Bluebird. And I still like hemoglobin A, especially if you've had a stroke for other reasons. However, if you have 2 alpha thal deletions, I would absolutely recommend anything that does a fetal hemoglobin induction instead, because I do worry about globin chain imbalance. But that's my only deciding factor at this point. Other thoughts? Dr. Hankins, what would you do?
I don't know. I am inclined to offer gene therapy. I think she would qualify. I don't think I'm ready to answer the question of which one, if that's what you're asking me. Yeah.
I was really just asking if you would. This is somebody who I do think is a good candidate. But it's interesting, right? She's somebody who I have a lot of concerns about how this is all going to play out and lots of thoughts about it. But one of them being that the FDA approval is for reduction in pain crisis. And she does have a lot of pain, but she doesn't come in a lot. And I really worry that I'm going to start seeing more people in the hospital to prove that they have pain crises that would have treated their pain at home.
Yeah. Well, but pain at home is also pain crisis, right? And that is diminishing quality of life. So,
Right.
I tend to listen to the pains that happen at home too, because those are important.
Oh, no, I agree. Yes, absolutely. I guess I was saying more from the payer standpoint. I worry.
I see. Yeah. It will be uncharted territory for us. This will be interesting.
It'll be an interesting, yeah. No, I mean, I think she's 38. She's very educated. She has when we talk about, for example, every time she comes in, I remind her that really the best way I could prevent her from ever having another stroke is chronic transfusion therapy. And she reminds me that she's been doing really well on hydroxyurea. She has great response and has been like this since she was 20. So 18 years on hydria. But she has I was worried she has no concerns with she's willing to do the transfusions needed and she doesn't have severe alloimmunization. But is able to have that conversation.
That's good. Yeah.
So Julie, out of curiosity, did she state why she was so interested in pursuing it if she feels like she's been doing okay?
Because she still has a lot of pain despite a really nice hydroxyurea response. And, you know, she would like to not have to live her life on hydroxyurea every day with worrying about her labs or those sorts of things, and hopes that this would long-term bring about better outcomes, even though we don't know. But that's her viewpoint. Anybody else? Other thoughts? And one other thing I think that makes her a good candidate is she's been very responsive to like feedback in terms of her own health. You know, she's was really not interested in doing appropriate iron chelation for a long time, but has done much, much better since actually moving from jade-nuded to ferroprone. Again, suggesting that she's, you know, she's pretty knowledgeable, understands the risks, is happy to see her ferritin going down, and, you know, we're going to get another liver MRI and all that stuff this year. But she was one of my first current patients who's come back and said, okay, now I'm ready. I want to do this, where she wouldn't have qualified for the studies because she isn't hospitalized enough. All right. Well, in that case, if no other questions or thoughts, anybody else? Last chance?
So I don't know if we want to open this can of worms. So, I mean, now that they're approved, what do you think the role of transplant is, like allo?
I think it's a really great question with a lot of different answers. And of course, we do everything here, so we get asked that a lot. And I try to really discuss the pros and cons of each. If you live far from a center, if someone's 2 to 3 hours away, and are driving to see me like this girl is, they're going to do, to me, it's going to be easier for them to do an autologous process, a gene therapy process. If you're located right next to a center, or I have another patient with a lot of resources who actually went to Nashville because they have a haplo protocol open, and I don't have an open haplo protocol right this second, so I referred them there. Then we have more knowns, right? We can tell you a lot more about what's going to happen after a haplo because we've been doing them for longer. But I do think that's how I'm using a lot of it, and just honesty, right? Here's what we know, here's what we don't know, and trying to make those shared decisions. Because I think there's pros and cons to both. There's no question in my mind that the first year after transplant, people feel better faster doing an autologous than a haplo, but long-term outcomes, we don't know. So I just have the best honest conversation I can. And also, you know, are they going to take their anti-rejection meds and all of those good things? Because we do have another young man who our first off-study haplo patient here, who 2 days after he got out of the hospital got really angry and decided he wasn't going to take any of his anti-rejection meds. And despite lots of mashing of teeth, got back on them, but eventually had really severe GVH. And he's alive, but has severe ocular GVH and has had corneal transplants now and is still blind in one eye. So it makes
Yeah,
you
that's
pause.
something I've been wondering about. Like, we have a couple people who have very bad disease, but also have a lot of social stressors and very poor follow-up. And I think from a follow-up perspective, I don't think would be safe to try to proceed with transplant, even though disease severity-wise, I think it's a reasonable consideration. But I've been wondering, like, in those situations, is it reasonable to try to just push through gene therapy, try to get better disease control, even with the social concerns, because there isn't, I don't think, as much long-term risk
I think it's a
with
great
poor
question.
follow-up.
Yeah, I mean, I will say that I don't know that gene therapy is the answer, but definitely wouldn't do an allo for anybody that you worry doesn't have the ability, wherewithal, social structure for support. You know, I got called out, as many of you all heard after the Bluebird talk at ASH, for the why wouldn't you just do the cheaper option? And the comparison to rehospitalization and the cost of GVHD is not small. So it's not just a quality of life, but it's also a cost issue. But of my 3 haplo patients, I've now had maybe 4 haplo patients. We've had 2 with really bad GVHD. And the numbers look good because they don't have a ton of acute, but they get a lot of chronic, and they do get better, but at a cost. And so I don't think there's an easy answer. And I think that's what I was aggravated with at that time at ASH, was pretending this is easy and, oh, we should just do the cheaper option because it's cheaper is not the right answer. You know, we should do, obviously, I think personally, whatever's best for the individual, and having a good discussion about it.
Do you think there will ever be a study comparing transplant and gene therapy?
I hope so, even if it is using some form of a, you know, of course, right, in my goal, we would enroll similar patients using something like Granddad, where we're capturing the data at least in real time in a head-to-head manner. So I don't know that there'll ever be a head-to-head trial in a true randomized fashion, because I don't know that anybody will ever pay for it. But maybe down the line there will be, once we get, you know, if base editing works, CRISPR is a whole lot cheaper than lentivirus, so maybe there could be at that point.
Yeah.
But I think it's a really good question.
Yeah. Yeah, but you're right. So through cohort studies, we could do synthetic arms, right, and compare that way.
Yeah. And you know, if they're big enough, and that's one of our hopes with Granddad, right, is not only that we can compare those, but we can compare the hydroxyurea patients.
Right.
So that we really have a sense, or our chronic transfusion patients.
Yeah, that's a good point.
Anybody else? Thoughts, comments? But I do hope we're working on kind of establishing some form of discussion forum for this, where we can debate the merits, because I think this is going to come up more and more and more, and it's going to be so helpful to have not just a multidisciplinary perspective, but a multi-institution perspective as our life changes in front of us. So with that, I'm going to introduce Dr. George to come take the stage, a pediatric hematologist oncologist, relatively new, yes, attending at
yes, just finished fellowship last year.
Congratulations. Who
Thank you.
is going to talk about something really interesting. I'm really excited to hear about this, about air pollution and sickle cell disease. And so I'm going to turn it over to you, sir.
Wonderful. Thank you so much for the opportunity. Let me see if I can figure this out here. Is this looking good from y'all's end?
That is perfect.
Awesome. Okay, so like Dr. Cantor said, my name is Paul George, a senior associate at Emory and Children's Healthcare of Atlanta, and I'm excited to talk to everybody about what essentially has been my fellowship research, but I'm hoping or am continuing on as a new attending. So title of the talk is Air Pollution and Pediatric Sickle Cell Disease and Overlooked. And what I hope I'll convince most people of is it's a potentially significant risk factor for severe disease among kids. So background, I know for this group, we really don't need to spend too much time on it. There's a lot of kids and adults with sickle cell disease in the country, characterized by these severe acute events. And even with, as we've been discussing with the case, first-line therapy, there still is significant morbidity and mortality, which in sickle cell disease, which I think underscores the fact that we both need to optimize medical management, but we also need to identify and mitigate risk factors for acute events and severe disease. So I think that involves identification, and well, I should say mitigation of risk factors we know about, such as viral infections, exposure to cold weather, but then also identify risk factors that we aren't yet aware of, or we don't have as much information on quite yet, which my hypothesis is would include ambient or outdoor air pollution exposure. So one thing that I'm hoping to hammer home with this slide is that I don't think of air pollution and sickle cell disease as a random risk factor in a random disease. Rather, because of the overlapping pathophysiologies of both, I think there's reason to think that kids and adults with sickle cell disease might be especially at harm or at risk for harm due to air pollution. And what I'll talk about now is just the pathophysiology of air pollution. So you breathe it in, goes to your lungs, makes sense. That's the first area that is harmed by air pollution. But similar to cigarette smoke, air pollution doesn't just cause damage with your lungs. It gets absorbed and causes a systemic inflammatory response. Air pollution also causes oxidative stress systemically. And then there's certain pollutants, such as PM 2.5, which I'll talk about in a later slide, that get into the bloodstream and can cause direct endothelial damage. So I think for a group that has knowledge of sickle cell disease, and for myself as well, it was hard to overlook the overlap between the pathophysiology of air pollution and the pathophysiology of sickle cell disease. And that was really the driving hypothesis of my project and my ongoing study, is that exposure to ambient air pollution is a risk factor for the development of acute events in pediatric sickle cell disease, and that this risk factor is especially prominent for kids with sickle cell disease as opposed to kids without sickle cell disease. Now, I'll talk about the data that I used for the study and the data that I'll use moving forward as well. So I'm here at Emory and Choa. We have a large pediatric sickle cell disease program. And the other thing that we have is a very good clinical sickle cell disease database, which thankfully doing my fellowship here, I had access to. So the database includes clinical, sociodemographic, and laboratory information on about 3,000 kids with sickle cell from the time frame that I looked at, which was January of 2010 to the end of 2018. The important thing that I want to mention too is that our sociodemographic data includes home address at each visit. So I'm able to see where kids live and make sure that the exposure matches, the air pollution exposure matches where these kids are actually living. Which brings me to the air pollution data. So the air pollution data, I think, is a pretty neat data source. I extracted it from NASA's Socioeconomic Data and Applications Center called CDEC. It's a publicly available data source, and it's obtained by combining NASA satellite imagery with air pollutant data from on-the-ground EPA monitoring stations. And so then by combining these two data sources, this essentially it's a combination of NASA, Harvard, and Columbia. They're able to provide one daily air pollution levels in 1 kilometer by 1 kilometer grids across the United States. So it allows for real precise and really down to the neighborhood level air pollution values. The other thing that I have this graphic here to remind me to mention is that air pollution, even though I keep saying air pollution, it's not just one thing. Instead, it's a mixture of gases, compounds, particulates. The graphic here shows PM 2.5, which stands for particulate matter that's 2.5 microns or less in diameter. So very small, much smaller than a human hair. And that was my primary pollutant of interest for a few reasons. One, I mentioned the pathophysiology, especially the fact that PM 2.5 is known to cause endothelial damage. I thought that would be especially relevant in sickle cell disease. And then also just stepping back from outside of sickle cell disease, PM 2.5 is probably the pollutant, or I shouldn't say probably, it is the pollutant that has the most data with regards to it being harmful for human health and other conditions outside of sickle cell disease. But there are other pollutants that I look at, like carbon monoxide, nitrogen dioxide, ozone, that you'll see. So then just briefly to touch on the model that I used in the outcome and exposure. So the main outcome for my study was the number of ED visits per day amongst the cohort. So essentially, I had this cohort of individuals with sickle cell disease. On January 6th, were there 8 ED visits. On January 7th, were there 10 ED visits, et cetera, et cetera. So that's our outcome variable. Our exposure variable then is citywide averages of daily pollutants. So essentially, I looked within a radius around one of the nearest Children's Healthcare of Atlanta hospitals. So it essentially encompasses the Atlanta metropolitan area. And I took daily citywide averages, and then actually the main exposure variable wasn't just the same day average, but was a rolling 3-day average. And the reason for that was this rolling 3-day average allowed us to account for the fact that kids might take 1 to 2 days to present to the ED after being exposed to pollution levels. And that's what's been documented, as we know, that kids often try and manage their pain crises at home for 1 to 2 days before presenting to the ED. So this allows us to account for that variability as well. The model also controls for time variables and weather variables, and then trends across time also, with the hypothesis, just to end on, being that the number of ED visits per day will be positively correlated with citywide daily pollutant levels. So essentially, higher pollution levels, I'm hypothesizing, will correspond with higher numbers of ED visits. Now, I'm going to be talking about incident rate ratios in the next couple slides. So just to get everybody on the same page, I'll just briefly define what they are. So the model, it was a negative binomial model. You can manipulate the coefficients, and eventually it gives you an incident rate ratio. And I've shown the equation there, but I think an example might be a better way of interpreting it. So for example, this isn't real data. This is just as an example, but if an IRR is 1.2, then for every standard deviation increase in air pollutant levels, we would expect a 20% increase in daily ED visits. If your IRR is around 1 or the confidence intervals cross 1, then you don't see an association. And an IRR of less than 1 would be a negative association. So that would be for higher air pollution levels, we actually see fewer numbers of ED visits. So now to get on into the results. So what we found, this is looking at the association of our primary pollutant of interest, PM 2.5, and how it is associated with ED visits amongst the cohort. And what we can see here with an IRR of 1.05 means that for every standard deviation increase in daily PM 2.5 levels, we see about a 5% increase in ED visits, which supports the hypothesis that PM 2.5 or that PM 2.5 levels are associated with ED visits. Looking at our other pollutants as well, we looked at carbon monoxide, nitrogen dioxide, and ozone. And you can see there that carbon monoxide was actually the pollutant that was most statistically significantly associated with ED visits and had the highest estimated effect size. Nitrogen dioxide almost reached statistical significance, but the confidence intervals did cross 1, and we didn't see an association with ozone. So those were the pollutants of interest among the sickle cell disease cohort. But if you'll recall, when I was in the background section, I was stating that I thought because of the pathophysiology of sickle cell and air pollution, that kids with sickle cell would be especially impacted by air pollution as compared to kids without sickle cell. So in order to test this hypothesis, we performed a comparison analysis in which we looked at all ED visits across the 3 CHOA EDs. We subtracted out the kids with sickle cell. So essentially we had a separate cohort that was all ED visits minus the kids with sickle cell. And then we ran these same models to obtain associations of ED visits with the air pollutant levels for children without sickle cell. And that's what we see with these black triangles and lines here. And what you can see is, again, it supports the hypothesis that kids with sickle cell would be especially impacted by air pollution because our estimated effect sizes are lower for all of the pollutants that we looked at. And it was only statistically significant. It was statistically significantly lower for PM 2.5, carbon monoxide, and for ozone as well. So then the next analysis that we wanted to run was to see if there was a difference in daily ED visits by genotype. Kind of similar to the fact that we thought kids with sickle cell would be more impacted than kids without sickle cell. We wanted to test whether kids with the more quote unquote severe genotypes, like essentially sickle cell anemia, so hemoglobin SS, hemoglobin S beta 0, were they going to be more impacted by air pollution than kids with less severe genotypes, such as hemoglobin SC. And I have the data presented there. Severe is the red X's, blue is moderate squares. And although the effect sizes are technically larger for the severe group than the moderate group, we actually didn't see a statistically significant difference in those two groups. So we couldn't make any claims about the difference based on genotype. Now, the last thing that I wanted to mention, and this kind of came up in the case discussion as well a little bit, was hydroxyurea. So we had the hypothesis that because of the inflammatory aspect of air pollution, it's known that air pollution exposure induces an inflammatory response in, there's not data there for sickle cell, but for otherwise healthy kids and adults, we know that being exposed to air pollution induces an inflammatory response. So our hypothesis was, would kids on hydroxyurea, because of its anti-inflammatory properties, actually be less impacted by air pollution than kids not on hydroxyurea? Could hydroxyurea actually have a protective effect with regards to air pollution? So what we did was we split up the cohort into a group that was consistently taking hydroxyurea versus a group that has never taken hydroxyurea. And what we have here are the results of that analysis. Blue is the group on hydroxyurea, red the red diamonds not on hydroxyurea. And what you can see is that for PM 2.5 and for ozone, it actually does fit with our hypothesis that the group that is on hydroxyurea is less impacted by air pollution than the group that's not on hydroxyurea. We didn't see that statistically significant difference in carbon monoxide, and I was honestly expecting to see a difference in nitrogen dioxide, but we did not see that difference there. So just briefly in summary of those findings, in the cohort-wide analyses, these daily air pollution levels were positively associated with EB visits among kids with sickle cell and with higher estimated incident rate ratios or IRRs than the all-child analyses. And then also in our secondary analysis, we did find that the cohort that was taking hydroxyurea was less impacted by changes in daily air pollution levels as compared to those kids not on hydroxyurea. But I will say the study does definitely have some limitations. It's in a cohort wide, so we're not able to look at individual level variables like how does sociodemographic status impact not only exposure to air pollution, but how well you're able to adapt to air pollution levels. And it also only looks at the acute complications of sickle cell disease, doesn't look at the chronic complications of sickle cell disease, which, given sickle cell is a chronic disease, you're exposed to air pollution over time, it might actually be the chronic component that's more important. And that's where I'm hoping to go to next is move this from an individual or from a cohort-wide analysis to an individual level analysis where we're able to look at those individual level factors such as sociodemographic status. And then we're able to look at cumulative air pollution exposure across time as opposed to just single point in times. So we'll see where that goes. And I think oftentimes a question that I get, which I think is a fair question when I bring up what I'm working on is, so what? Why does it matter? It's really nobody. There would be very few people out there who would argue that exposure to air pollution is a good thing. And I have a couple of answers for that. One, from a patient counseling perspective, I think these findings suggest perhaps that as hematologists, maybe we should be advising families when you get a iPhone alert or a alert on your phone that it's a high pollution day, maybe those would be good days to stay inside. Another thing we can do is counsel families on more proactive measures of air pollution avoidance, such as telling patients and their families about the importance of changing AC air filters every 4 to 6 months. I have, through this study, I work with a couple of pulmonologists, and that's something that's becoming more common for kids with asthma is they're counseling that, the best way to lower your air pollution exposure is making sure you're changing your AC air filter every 4 to 6 months. So maybe sickle cell is another group that we should consider high risk and have that as just a routine part of counseling because it's really a pretty cheap and effective way of lowering your pollution burden. So that's from the individual perspective. But then two, from a health policy perspective, if you look at the EPA's mandate, they're supposed to protect not just entire populations, but also the most vulnerable populations from the harms from air pollution. My argument would be that given the pathophysiology of sickle cell disease, given the sociodemographic characteristics of patients with sickle cell disease, and we know that Black patients, due to our nation's history, or Black families, due to our nation's history, are just more likely to be residing in high air pollution areas. I think it's important for these government agencies when they're looking at standards to include the most vulnerable groups, which I would argue includes patients with sickle cell disease. And with that, just thanks really to all of you all for offering me the opportunity to present here. And of course, I'd love to take any questions, comments, and I'll stop sharing.
Awesome. Thank you. Amar, would you go ahead and ask your question out loud and introduce yourself?
Yeah, sure. Do you hear me?
Yes.
Yeah, so I'm a pediatric pulmonologist, and this is kind of one of the areas of my interest. So thanks so much, Paul, for focusing
great.
on the effect of air pollution on sickle cell disease. So my question is, in the past, there have been an idea that you can use carbon monoxide to treat sickle cell disease because when carbon monoxide attached to the red blood cell, it will shift the oxygen dissociation curve to the right. So it increases the affinity of the red blood cells to the oxygen and decreases the sickling. And it was proved that it decreased the sickling. So there are even some epidemiologic studies that show that kids who live in areas with a little bit higher CO level, they can have less sickling related events. But in your data, it was like when the CO level was higher, there was increased painful episodes. So I just want to see, like, what's your explanation about that discrepancy between the two data?
No, I think that's thank you for bringing that up. That's a really good point. And there's actually a group here who has looked at, before I did this study, who has looked at carbon monoxide as well. So I will say these were surprising results. The best answer that I can give is that this was a epidemiologic associational study. So there might be something else that's associated with carbon monoxide that would be driving this, because like you said, it does not correspond with the carbon monoxide data that you previously laid out. So is there something else? I tried running multi-pollutant models to see, well, let's see if we look at both PM 2.5 and carbon monoxide as exposures to see if that could help clarify things a little bit more. But given the sample size and then the correlation between the different pollutants, the model didn't show us anything interesting. Essentially, our confidence intervals just got too wide for us to be able to make any sort of association. So that's the best answer that I think I've been able to come up with, because like you mentioned, there's another group here who is looking at that and would have hypothesized, I think, that carbon monoxide would have either been insignificant or gone the other way, but that wasn't what we found. I don't know if you have any thoughts. I'd love to hear them as well.
Yeah, no, that's exactly what I was thinking about, because usually the sources of carbon monoxide, which is usually the exhaust kind of emissions, they're the same source of the PM 2.5. So that was my idea, is that it's not because of the CO itself, but because those who are exposed to higher CO level, they're also exposed to higher NO and higher PM 2.5 and PM 10 levels. And this effect will be diluted by the others. So that's exactly what was my next question. What happens if you control for the other things and see if the relation is still significant? Because if you control for the 2.5, as you mentioned, and then the variability is too much and there is it's no more significant, the exposure to the CO, I think that would be something significant to report, because then we know that it's most likely it's because of the PM 2.5 rather than CO itself. But yeah, right. That's exactly my thoughts.
Okay, great. No, that's good feedback. I appreciate it.
And in fact, I'm working with a PhD student now on her thesis. It's not exactly the same, similar to your work, but it's close to your work. So I think it will be helpful to communicate, me and you, and see how we can collaborate in the future.
That would be great, actually. Yeah, I can shoot in the chat to you or my email.
I can connect you guys, don't worry.
Oh, perfect. Thank you.
Thank you.
Dr. Chibuzzo Alonzi asked a question that I have similar to, which is, did you take into account the diagnosis of asthma, and do you have that in your database at CHOA?
So asthma I've presented this a couple of times, and I often get the asthma question. I should state this up front because it's a very good question. And our database team here, who's worked on the database, like Dr. Lane, who's been in charge of the database for a while, asthma is kind of, or I should say, is one of the areas where we have just a lot of trouble extracting true asthma diagnoses the way we do it from the EMR. And essentially his thought, and I respect his thought on this, is that the way we're pulling out asthma diagnoses now just isn't capturing asthma correctly, because so many of our patients who we see will come in, they'll come in with some sort of respiratory symptoms. They may or may not have a diagnosis of asthma. They'll get put on albuterol, and then asthma will kind of follow them through the chart. And so that's kind of a long way of saying we don't have now a good way of pulling out asthma from from the medical record, who truly has it and who doesn't. And I think that's I know that's one of the main limitations of the study, because I think that would be quite interesting to look at. And then I see the other part of the question was, did we look at reason for ED presentation? We did look at that. And if you just look at VOC versus non-VOC, the VOC VOE has a little bit of a greater effect size than the non-VOE, which I think is what we would expect. But then if you look at if you try and like pull out, similar to trying to pull out asthma, if you pull out respiratory diagnoses, you don't see much of a difference there.
Thank you. Amar?
Yeah, just commenting on the asthma again, just because my field and we've done studies about the effect of asthma. And your comment is totally correct, which is most of the epidemiologic studies that used asthma as a confounding factor or a main outcome or input to the outcome, there is no usually objective kind of studies to confirm asthma. We mostly depend on physician diagnosed asthma. So I would suggest studying the effect of asthma, because it's very well known factor, because it is very nice modifying factor. It is affected by the pollution, and it can cause a lot of sickle cell complications. So if you have a patient who was diagnosed with asthma by a physician, then most likely this patient have an asthma, even if they don't have a lung function test, they don't have a pre and post bronchodilator test or full PFT or other kind of objective asthma diagnosis test, and see what's the effect of this as a modifying factor, because probably the asthma will be kind of the modifying factor that mediates the effect of PM 2.5 into this, or it may be just the direct effect of PM 2.5 on the endothelium, as you said. But it's very important to study the effects of asthma in this kind of scenario.
Yeah,
Thank you.
absolutely.
I agree with Chukwuzo.
Dr. Sa?
Yeah, hi. Thanks, Paul, for this presentation. I've listened to it before, and every time I'm fascinated. A couple of comments to Dr. Amar's point and Dr. George's rebuttal. Yes, when you're looking at registry or database, you just have to go with what is. And I think in anyone who is developing any kind of registry, SCAPN, ASH, CTN, you have to define. Otherwise, then you end up getting meaningless things when it becomes fluid. So the patient in front of you and looking at the database, with me being involved in a database, are actually two very different things. We end up we're creating a working group through our EPIC, so that we can now have all our patients across all subspecialties have their definitions captured in EPIC. And we have to agree with the ICD-9, because now you're pulling different things. You have ICD-9, you have ICD-10, and then you might say, if a patient came in with wheezing and reactive airway disease, what constellation of things which you see in the medical record will give you a 99% or higher probability that this is actually the diagnosis that you're using. Because if somebody came once and had RSV bronchiolitis or acute chest and exacerbation and was given albuterol ×1, they end up having reactive airway, something in the chart, as he said, that follows them through life. So maybe in the next few years, when our EPIC, we've sat down with the pulmonologists and defined and had those definitions clear, that a constellation of 3, 4, 5 things in the medical record are more predictable or more accurate of that diagnosis, then it will be more easier to ascertain. I think, my follow-up question to Dr. George would have been, for the patients who did not have sickle cell, the cohort that you compared with, the non-sickle cell cohort, could you have separated them again now using the EPIC definition of those things, wheezing, bronchiolitis, asthma exacerbation, patients who do not have sickle cell disease and are coming for these just isolated pulmonary things may be more likely to have some, reactive airway disease. If you teased your non-sickle cell ED visits to just respiratory or pulmonary complications, bronchitis, bronchiolitis, reactive airway exacerbation and all of that stuff. Could you have seen that there may have been a parallel there as opposed to sickle cell with the diagnosis?
So that's a great point and question. And unfortunately, I would not have been able to, because the data that I got for the all ED visits came from a CHOA data pool. And essentially they told me that in the time frame that I was hoping to get it, I could get counts and ages. But if I were to need ICD-9, ICD-10 codes, then that would be kind of a whole other bag of worms that would have required more funding, et cetera, et cetera. So I didn't have that information, because in my dream world, I would have had that information as well as better address data as well for the whole group. Because I have great granular data on addresses for the sickle cell cohort group, but I don't have that for the non-sickle cell cohort.
Thank you.
Any other questions? Well, thank you. That was great and super interesting. And I will send you a copy of the paper that I'm on and tell you all the things that I think are wrong with it. It's about air pollution that I worked on. It's been ongoing for years, and unfortunately it goes back to the database question you just discussed, and the colleagues that I was working on, most of whom are no longer even there, and it's a new set of people that I don't know. But anyway, they used a really poor administrative definition of sickle cell disease and not one that's validated. So I think it is kind of negated half the paper, but I'll send it to you anyway, just for your perusal.
Yeah, please do.
I will.
Thanks everybody for the questions.
Yeah, thank you everybody for coming. And again, in the chat, there's a couple of links. If you didn't see them, we can certainly send them out to you. Just let Sonia know, and we'll see you in a couple weeks. Cheers.